Over the last 30 years, remarkably little has been done to document the history of financial, therapeutic, and operational policy with respect to addiction and behavioral treatment. As part of our mission, C4 has developed a series of films capturing this important oral history. Over the last 30 years, remarkably little has been done to document the history of financial, therapeutic, and operational policy with respect to addiction and behavioral treatment. As part of our mission, C4 has developed a series of films capturing this important oral history.
A lot of my work has been involved over the last, 30 years really, in trying to help the addiction treatment field move away from program-driven treatment to person-centered services, to move away from predetermined fixed lengths of stay from which people complete and graduate to a chronic disease management model where we move people through a continuum of care at the pace that makes sense to their particular severity of illness and level of function. And the reason for this is to increase access to care by cutting down on waiting lists, where people often can be stopped up in residential levels and not able to move on and increase access for people needing to get into those levels, and also to be good stewards of resources, where we make sure that we're using resources to stretch to give people as much care as possible, because that improves outcomes. Not to give people more care than they need, because that's wasteful of resources. Not to give them less care than they need, because then they get sicker, and that costs more both in human cost as well as financial resources. And that's really part of the mission of the ASAM criteria, to provide a continuum of services so that people can get all the care they need, but also to make sure we stretch those resources as far as possible.
David Meelee MD is a board-certified psychiatrist and is certified by the American Board of Addiction Medicine. He trains and consults both nationally and internationally. Dr. Meelee is chief editor of the ASAM criteria and is a senior advisor to the Change Companies.
I'm a board-certified psychiatrist and now an addiction medicine, addiction psychiatry specialist. But when I got into the fields, fresh out of my psychiatric training in the Boston area, I was assigned to an addiction treatment team on an inpatient psychiatric unit. And I was assigned to that team not because of my exquisite knowledge about addiction, but because they couldn't get anybody to work on that team. So I was the new kid on the block, and I had to get on-the-job training around addiction from recovering counselors and other people in the field who'd been there much longer than me. So I'd had good medical school training, good psychiatric specialty training, but they didn't teach you not much about addiction, unfortunately, except the physical liver problems and all of that. So getting on-the-job training was a good opportunity to really get to know what addiction really looks like. And actually, I got more and more interested in it because I saw people get well much more quickly than my schizophrenia patients and my personality disorders and depression. And of course, with addiction, if people get into recovery, they don't just get back to baseline, they do even better. So that was exciting to see people not only get well, but to get better than well. So that got me more and more interested in addiction treatment. Well, I got out of my psychiatric training in 1977 and then went into private practice in a hospital-based setting. And that team I worked on, and then a few years later in 1981, so worked in that team from 77 to 81. In 81, we pulled out that team and put it on a separate floor in the hospital, and I started up and directed a 16-bed inpatient treatment unit specifically devoted to addiction treatment, and also because we were part of the Department of Psychiatry, working with people with co-occurring mental health issues. And back in that time, in the early 80s, a lot of the programs in the Boston area were called alcohol rehab units or alcohol treatment programs. And we called ours an addiction treatment program because we realized that there was a need to be broader than just alcohol, and so we were treating other drugs as well. There had been at Eagleville in Pennsylvania a focus on starting to do more combined treatment in the 70s, and so we weren't the first, but we really were, early on in the Boston area, one of the first to start recognizing addiction as a disease, or not just alcohol and then drug addiction. People were still often thinking of them as two separate things with separate departments at the state level and separate policies and so forth. So really at the beginning of the 80s, we started to think more broadly than that. And we set up our program as a 21-day hospital-based program, but that was because in Massachusetts at that time, there was a mandated benefit for every citizen of Massachusetts for 30 days of hospital level of care, and there was a mandated outpatient benefit, but just $500 for the whole year. So if you're going to set up a program, guess where you would do it? In the hospital. And we made ours a 21-day program because that left over a few days in case they got, if they relapsed. But looking back on that, that was not really a very scientific way to develop a program, because soon after we opened up, Blue Cross Blue Shield of Massachusetts said you shouldn't be having these fixed length of stay programs. And all of the treatment providers, we got together and we're trying to fight that and to go to the legislature to get them to get off our backs. But as a physician, I got to thinking, well, why is it a 21-day hospital-based program? We don't have, 21-day diabetes programs, 21-day schizophrenia programs, 21-day hypertension programs. Every other illness we treat depending on the severity of the illness and their progress in treatment, not a fixed predetermined length of stay. So that was really the beginning in 1981 when we were confronted with why do you have the model you have, for me to start thinking about what would be good addiction treatment and how would we treat it like we treat other chronic illnesses, with a continuum of care, not just one level of care and not just a fixed length of stay program. That led me to really think more carefully about how do you decide who belongs in what level of care. And so soon after we were confronted with our model of care, as I was sitting in treatment planning meetings, I'd noticed we'd talk about just a same number of issues for every patient, and I developed a little instrument called the Recovery Attitude and Treatment Evaluator, RATE, R-A-A-T-E. And my friend and colleague, Dr. Norman Hoffman, did some scientific work with that and look at the validity and the reliability of it. And that was really the beginning of looking at a multidimensional assessment, looking at biopsychosocial aspects of a person's functioning to then determine what's their particular severity of illness and level of function, and then, like we do with other illnesses, match that with their particular intensity of service needs in an individualized treatment plan done in a level of care, but then to move that person through a variety of levels of care. And in about 1986, the Cleveland, Ohio programs were also being confronted by the insurance companies and Blue Cross of Northern Ohio, I think it was, they were confronting those programs because they had 28-day residential programs. And so they said, well, we shouldn't just object to their criteria if we don't have something better to offer. So unlike us in Massachusetts, where we had just tried to fight the managed care and the insurance companies, they said, we're going to fight it, but we're going to be proactive in developing some criteria of our own. So they put out a request for proposals, and Dr. Norman Hoffman and myself and another psychiatrist, Jim Halikas, got the contract to develop what eventually would become the Cleveland criteria. And these were the first criteria really that used a multidimensional assessment of a person to assess their severity of illness and then to match that with an intensity of service, a level of care, and a variety of levels of care in a continuum of care of addiction services. And so the Cleveland criteria were getting some attention. They were published in 1987, and at the same time, NATAP, the National Association of Addiction Treatment Providers, looked at those criteria and they said, well, we should have some criteria, and they developed under the leadership of Richard Weidman the NATAP criteria. So the Cleveland criteria were sponsored by the Northern Ohio Chemical Dependency Treatment Directors Association, and the NATAP criteria were sponsored by the National Association of Addiction Treatment Providers, a guild organization of mostly residential programs at that point. And so we had these two sets of national criteria that were getting some national attention around now having some criteria that might counter the criteria from insurance companies and people who were often more focused on saving money than they were on developing models of care for good addiction treatment. And then I became chair of a committee in what is now called the American Society of Addiction Medicine, ASAM, and in the late 80s became chair of a committee on looking at quality of care. And as the chair, I said, well, these two sets of criteria, the Cleveland criteria and the NATAP criteria, we're a small enough field that we should not be competing with criteria. Why don't we have one set of national criteria? And graciously, both those organizations, the Northern Ohio Chemical Dependency Directors Treatment Association and NATAP, gave up their criteria if they would be combined in one national set. And so we set about that work in the late 80s with representatives of both organizations and an interdisciplinary team of addiction specialists, counselors, psychologists, social workers, physicians, and pulled together, content from both those sets of criteria to then develop the first edition of the ASAM patient placement criteria in 1991. I've been chief editor of all editions of the ASAM criteria, which span 1991, the second edition in 1996, the second edition revised in 2001 when we included criteria for people with co-occurring mental health issues and improved and renamed some of the assessment dimensions to include mental health. And then the current edition, 2013 edition, the ASAM criteria. And so I've been with that process where for, since 1991, we've been talking about what would a good model of a continuum of care services look like for addiction treatment. And while that has been a good project, it's not until the last about 3-4 years that the Center for Medicare and Medicaid Services, Center for Medicare and Medicaid Services, CMS, they said to states, you can apply for a waiver to redesign what you have to use the ASAM criteria. What they said initially, and currently they say you can use the ASAM criteria or some other set of criteria, but suddenly the ASAM criteria, the American Society of Addiction Medicine's criteria for levels of care, started to move from nice to know to need to know. In other words, states that were applying for this waiver suddenly needed to understand, how do we redesign all of our services to match a flexible, seamless continuum of care, which is what we were promoting with the ASAM criteria. So a lot of my work then has been involved over the last 30 years really in trying to help the addiction treatment field move away from program-driven treatment to person-centered services, to move away from predetermined fixed lengths of stay from which people complete and graduate to a chronic disease management model where we move people through a continuum of care at the pace that makes sense to their particular severity of illness and level of function. And the reason for this is to increase access to care by cutting down on waiting lists, where people often can be stopped up in residential levels and not able to move on and increase access for people needing to get into those levels, and also to be good stewards of resources, where we make sure that we're using resources to stretch to give people as much care as possible, because that improves outcomes. Not to give people more care than they need, because that's wasteful of resources. Not to give them less care than they need, because then they get sicker, and that costs more both in human cost as well as financial resources. And that's really part of the mission of the ASAM criteria, to provide a continuum of services so that people can get all the care they need, but also to make sure we stretch those resources as far as possible. If you get your appendix out and they don't say you have to stay here for 10 days because it's a 10-day appendectomy program, you leave as soon as you don't need to be there, but you also need to have continuing care if you're going to get good outcomes. So the treatment field really, in moving from the 80s to the current 2019, there's still a lot of programs and a lot of patients and clients and people who think of addiction more as send somebody off to rehab from which they graduate and then sort of like they're cured or something. But this is not a disease you just sort of like a broken leg, wait till it's healed and then you're done. So unfortunately, a lot of the public and a lot of patients sort of say things like, how long do I have to be here? And if they hear an answer in numbers, that's really more of a program-driven model than, I don't know how long you need to be here. We have to do an assessment first about what your needs are. Then we have to work together on a treatment plan that you are willing to actually do. Then we have to see if it works, and then we have to see where can we deliver that treatment plan in the least intensive but safe level. Least intensive because we don't want to give you more care than you need, but it has to be safe. So it's not just the least intensive level, but the least intensive safe level. And then how long you stay in that level depends on how you're progressing. So at the point that you don't need that level, we'll transfer you. And if things are getting worse and you need a more intensive level, we'll transfer you to that. So either way, we'll give you the care you need, but we'll also do it in a way that matches your particular needs, not everybody getting the same thing. Addiction treatment is coming to this much more late after other illnesses that increasingly all of healthcare is moving, or has moved really, and addiction treatment is behind the 8 ball on this, to outcomes-driven treatment, that we'll reimburse you for outcomes, not just for you doing services. And so increasingly, for all other illnesses, and that this has been going on for years. So if you think about cancer treatment, people have for years been studying what's the right combinations of treatment to get a 5-year survival rate or a 10-year survival rate. And they keep tweaking treatments to improve the outcomes. In the addiction treatment field, unfortunately, we still, in many ways, are back in the 70s and 80s, where the focus has been on come to our program, and if you come here for 28 days and then you re-up to the longer-term program, it's still a very program-driven model. But what is changing in the addiction treatment field, for example, the Joint Commission, which accredits hospitals and other treatment programs, one of their accreditation standards that they were the first to introduce about a year or two ago was that the program has to work and use some kind of standardized outcome tool to measure outcomes in real time to make sure that a person's treatment plan changes depending on whether they're improving or not. So there's the beginning in addiction treatment of saying, we're not just going to pay you for the services you offer, we're going to pay you if you start demonstrating that you're changing your treatment based on a person's outcome. Now, this is no different from, unless money's no object, when you go to buy a car, you're interested in what's the EPA gas mileage, you're wanting to know what's their record in terms of how often repairs have to be done. You make a decision based on the quality and the demonstrated outcomes of that machine. And the same in terms of choosing hospitals or choosing a surgeon. You wouldn't want to go to a surgeon who has a 50% death rate or something. And same in addiction, what we've often done is choose whether you have a spa or whether you have equine therapy or whether it's near the beach, and many of these things that really don't have anything to do with outcomes and whether you're effective. So we're still sort of expecting people to pay for services regardless of whether the outcome is good or not. And that's changing, that has changed in all of other healthcare, and it's got to change and will change in addiction treatment as well. So when you decide where to go, it's not going to be just on reputation or a caring staff, as important as that is. It's going to be dependent on what's your 5-year recovery rates, not just of people who completed your program, but overall. And if you have a 30% dropout rate, why are people dropping out of your program? And these kinds of metrics is where we have to get. And what that's called is feedback-informed treatment or measurement-based care or measurement-based services, where in real time people are assessing on a variety of standardized instruments how are you doing, and depending on your progress, changing the treatment plan in real time. So for example, programs that are doing this may give to a patient who's sitting in the waiting room a tablet, your Apple iPad. They'll fill out a number of standardized instruments. That information goes straight to the counselor before they see you. You go into your appointment, and based on I notice your craving score is going up, and I notice your depression has increased, and I notice that your anxiety has decreased, but your depression has increased, or I notice that you having cravings every day. What do we got to do in this treatment session to help you with those issues? That's measurement-based care. That's measurement-based services, measuring your quality and outcomes, and then changing the treatment plan. Now, we've been doing that for years with hypertension. The first thing you do when you see the doctor for your blood pressure is they take your blood pressure. And if it's way up, they're not going to say, well, I'll see you next week. They're going to say, we better change the treatment plan today. And if we change the treatment plan today, that's because we're not getting good outcomes with your blood pressure management. But we haven't got that model in addiction treatment enough, and that's where we're going to have to move, because right now it's often just based on philosophy or program design or idiosyncratic sort of things that really don't demonstrate the quality of care. I've done a nice piece of work, and I'm at an age where it's time to start moving that on to other people to continue that work. And, a lot of my contribution has been in trying to move the field away from program-driven care to person-centered outcomes-driven care, to move from fixed length of stay to more flexible lengths of stay in a continuum of care, to make sure we're using resources efficiently but with high quality. And really that is a paradigm shift that unfortunately still hasn't fully been realized. And so I suppose when I want to grow up, I want to see that fully realized. But I know that I'm not going to be the only one to make that really come to fruition. I've also done a lot of things with trying to integrate mental health and addiction treatment, because people don't just come in with addiction or mental health. They come in with often a big overlap between mental health issues and addiction treatment issues. So that's another area that I've focused on, and also motivational interviewing to engage people and attract people into recovery. A major piece of what I've done, though, is what we've been talking about as chief editor of the ASAM criteria. Over the last 22 years probably, I've been going to Santa Clara County in California, in Silicon Valley, the San Jose area. And we introduced the ASAM criteria back then in 1997. And they, out of all the counties in California, which is one of the states that is revamping all of their systems in keeping with the ASAM criteria, they're one county that has struggled for 20 years in trying to develop the kind of system that's consistent with, chronic disease management of addiction. So that's one area that is certainly not perfect, but they have been thinking about this a long time. And so we're really at a turning point of treatment providers and payers trying to come together to think, how do we develop this kind of system of care? And there's some people that have been trying with it, but there's still many obstacles at the state level. So what I say is that it really means a big systems move where you have to get payers and providers and administrators and quality people who audit programs to come together around what kind of system do we want. The other area that's changing is the criminal justice system, as they look at, we're not effective in just locking people up, and that doesn't increase public safety. How do we help those who have addiction get help? And so that's another new frontier where judges and attorneys and probation officers and others are beginning to understand what good addiction treatment is, and working together to really develop systems that can help restore people to improve public safety and to get them into recovery. So that's a new area, not brand new, because drug courts and treatment courts have been around since the 80s, but what's new now is, I think, that they're more open to looking at what good addiction treatment is, and to see if everybody can work together better to get the outcomes we all want. Addiction is still very stigmatized and discriminated against, that there's still so much public discrimination against addiction, and in the treatment provider world as well, because unfortunately physicians are still not getting the training they need in medical school, in specialty training, and police officers and law enforcement who get involved with people with addiction. At every level, there needs to be an understanding about addiction and helping people. Now, the opioid crisis has increased that awareness, but it's not just about opioids, it's about addiction. So yes, somebody may go into the emergency room with driving drunk and get a broken leg, but often they will just stabilize the broken leg and not make the diagnosis of addiction and not even get them into continuing care. And the same is with criminal justice. Somebody will get arrested for a substance-related charge and they just get put through the incarceration system. And same in mental health. Somebody will come in with a substance-induced psychosis. They stabilize the psychosis, but nobody says, oh, you were using substances, maybe you have addiction or a substance use disorder. Are you getting treatment for that? Now, that would never happen with diabetes. If somebody came into the emergency room in diabetic coma, they wouldn't just stabilize them and say, have a nice life. If somebody came in with an asthma attack, they wouldn't just help their breathing and then say, see you later. They'd say, do you know you have asthma? Do you know you have diabetes? Are you getting treatment? That doesn't happen often with addiction. And so where we have to start is making sure at every level, law enforcement, mental health, emergency rooms, primary care physicians, how do people get the training and destigmatization and discrimination against people with addiction so that when people show up, and they will show up, they won't show up saying, I have addiction, I want recovery. They'll show up depressed or some other physical health problem or mental health problem, but then that we then screen for and identify. And there's increasing focus on screening and brief intervention, referral to treatment, but it's still not broad enough for the millions of people who have addiction, who interface with all layers of society but aren't detected, or even if they are detected, then aren't hooked up with treatment because they may object to being detected. Most people with addiction don't say, thank you for giving me the diagnosis, I'll go into recovery. At every level and every part of our system, we still have this discrimination against this disease, and that means people aren't getting the services they need, or they're getting it too late when they're terminal. We wouldn't do that with cancer or any other illness.